Hi, I'm Juliet Choi, very honored and humbled to serve as your moderator today. If you are passionate about community voice and visibility, then you are at the right conversation for this afternoon. I think all of us really do appreciate that community voice, centering families, especially I think communities of color and underserved populations, is absolutely key. And in my own opinion, I really think community leadership really drives innovation in many different ways. And throughout the day, I think many of us have been channeling Dr. Gail Christopher. She said, shared so many words of wisdom. And I want to hold on to, while day to day, I think we do feel like we're facing challenges and we're always in the fight, I guess in warrior mode. It's really also important to celebrate, uplift, and put the spotlight on some of our terrific community leaders who really are driving change and systemic change. So today we're going to talk about community partnerships and how community partnerships really can shape healthcare. We hope to cover some innovating practices, ideas. We want to see what we can share with an eye towards scaling these opportunities, sustaining, and integrating a lot of these efforts in maybe some of the work that we do in our individual capacities. So and actually let me just raise one more point. We've also been talking about the 20th anniversary of unequal treatment. If I can share, one of the chapters in the original publication on civil rights dimensions, if you look at footnote 3 or 4, in really tiny print, you'll see my name right there. At the time, I was a humble, eager, naive legal research assistant, but was really just, that really drove my passion to study civil rights law. So I'm one of those civil rights attorneys or recovering attorneys in Washington, D.C. Again, pleasure to be with you here. Without further ado, we have a phenomenal panel here with just years and years of wisdom. And so I'm going to turn it over to Neicey, and if everyone could just introduce yourselves.
Thank you so much for that. And let's make sure we're on. Yep, camera. My name is Neicey Johnson, and I am a nurse attorney from the South, yay. And I am also the COO for the Association of Black Cardiologists. And in my part-time work, which is volunteerism, I am the immediate past chairperson for the Georgia CTSA, which is the Clinical and Translational Science Alliance, that is an alliance of the 4 major universities in the state of Georgia. And in that role, I served as the chair for the steering committee, which was our community engagement core. So I think I can bring a little bit uniqueness to the conversation today, having a clinical side as well as being part of a CBO and being part of having to deal with health systems and navigating through those and the excitement around that. So I look forward to the conversation today and hope to be able to bring some perspective on how we can do things differently and some solutions that may be able to move us forward in the process. Thank you.
Wado. Hello, test. Wado. I'm Mark Rogers. I've been a CEO in healthcare for about 35 years. I've been in charge of 6 different hospitals in Oklahoma, for-profit, not-for-profit, and a couple of Fortune 500 companies. And I've also been a tribal health executive for the last, oh goodness, now about 15 years. So very happy to be here to talk to everyone today. I'm also, my family and I are members of the Cherokee Nation and active in our tribe. And it's going to be exciting to talk and share with you some of the things that we do in our tribal community today. Thank you.
Hey y'all, how are you doing? My name's Alex Sheldon. I use they, them pronouns, and I am the Executive Director of GLMA, Health Professionals Advancing LGBTQ+ Equality. We are the oldest and largest association of LGBTQ+ and allied health professionals in the country. We've actually been around for over 42 years, and we used to be known as the Gay and Lesbian Medical Association. But in recent years, we expanded so that we could actually encompass a membership that was multidisciplinary. So now we include not just physicians, but nurses, PAs, basically anyone who touches the healthcare system. And we also expanded so that we could ensure that we were representative of the entire LGBTQ plus community and not just gay and lesbian folks, as our moniker used to say. So our mission is actually dual-fold. One, we advocate for health equity for LGBTQ plus communities all across the country, and we also work to support LGBTQ plus health professionals in their work and learning environments. And we think of those things as very much interconnected. And so my entire background is actually in public policy, so it's really my privilege that I get to take that really brilliant expertise from all of our health professionals who actually get to combine their work in education and their lived experience as LGBTQ plus folks, and I get to use that brilliance and channel it into real systemic change through advocacy, research, and education. So really excited to be here with y'all today, and thanks so much for having me.
Wonderful. So to kick it off, could I start with, let's start with Alex. From your perspective, can you name a successful community partnership model that you've observed, worked with, associated with? Just want to make sure. I have no doubt we've got lots of rich stories, and I just want to find a way to facilitate sharing some of those stories with our wonderful audience here.
Yeah, absolutely. And I really think something that on the last panel that really resonated with me is that the opposite of bias is reality. And so when I think about community-based approaches, I think about actual representations of our lived realities. So if you only have one person sitting at the table, that is not a true representation of the human experience. You need to have multiple perspectives, multiple intersectional perspectives in order to have a community-based design. So one partnership that I think GLMA is particularly proud of is our partnership with the AMA, the American Medical Association. So we are the only LGBTQ plus organization with a voting seat in the AMA's House of Delegates. Mm-hmm. And so we use that position in order to represent not just the health professionals in the space, but all of their myriad they're all of their clients and their patients as well. So as an LGBTQ plus health professional, they are more likely to see LGBTQ plus patients and clients. And that means that they have an incredible amount of expertise at their fingertips, and we're able to take that and channel it into real policy wins in the AMA's House of Delegates. And then that also means that we get to work with amazing partners like the NMA and a few others that are able to represent so many intersectional identities along with us. And what that says and what we advocate for is the patient-centered community approach. We think that patients and their rights to healthcare and their rights to equitable healthcare should be at the center of all policy and decision-making. And so that is one way we're able to channel that into our actual wins and into a partnership experience there.
Mark.
Communication and being at the table, I think, is the key point. You know, when people are talking, they're communicating and they're working things out. And you can't work things out if you're not talking. You can't talk if you're not at the table. So I like the word intersectional, because that's an important word. And when you're delivering healthcare in any kind of healthcare system, I work, as I was saying during the introduction, we don't just take care of Native Americans, we also take care of people in the local community that have insurance, or we have our sliding scale. So we actually service the whole community. And so in designing our services, I have to balance between, you know, the tribal elders and the tribe, making sure we're taking care of all of our Native Americans. That's why we exist. The federal government gives us money in our compact and our treaty. But then the money we generate, the third-party revenue, has to be rolled back into our system, and that's how the federal government sets us up. So by rolling that money back in, we can do other things to serve the community and open up additional services, hire additional doctors, try to recruit folks to our community and to work in the tribe to serve various groups. And we look at trying to match people that, you know, a lot of people are not clamoring to come to rural areas. You have to really sell it. You know, and but we've been very successful with that, and I think that keeping that conversation going with us, and what I do, and what's very important to me, is I always do a community needs assessment wherever I go. When I go into a new market or a new area, and I ran two Fortune 500 hospitals here in Oklahoma City. We facilitated reaching out, talking to all the communities that we serve, because we don't just serve one part of Oklahoma City or this part, we serve everybody with our services. And getting those inputs and rolling them back into an action plan. And some of those things are really easy, like low-hanging fruit. You can knock those things out. You don't have to make it into a big, elaborate plan. And then do some things that's actionable, and then explain to your board what you're trying to do, get that support. And I think if you're doing things like that in good faith and with the right intention, it's easy to get everybody on board with you on that.
Great, great.
And I think from our perspective, twofold, with the Association of Black Cardiologists as a national CBO, one of the models that we found to be very helpful in terms of how we connect as providers back to the community is through a couple of signature programs that we have. And one is what we call our Community Health Advocacy Training Program, which is a twofold program. It provides the opportunity to train community health workers in select communities to actually take the messaging around cardiovascular wellness and how do they improve that and mitigate risk factors within their own community. So we do an intensive training for them, and then we follow them for 12 months and build sustainability models ongoing forward. Right now we have about 20 of those sites throughout the U.S., and we aim to add 5 new sites each year, depending on funding. So we're excited about that program and the impact that it is having in communities, and especially in communities of color. And then secondly, in my role with the steering board committee on the CTSA, our steering board is a model that is a little bit unique to others, where it is community-led. So we have 20 seats on the board itself. It is led majority by the community members, and it is obviously we have community members at the leadership role. And we make certain that we invite our academic partners and others to come to us to talk about their programs and how to engage the community, how to engage people of color, how to recruit patients if they're doing a research study. And then we put them into tiers. And those tiers enable them to either have direct mentorship through the committee, or they can actually look for funding and look at opportunities on which they can actually expand their model through our mentorship program or just discussions that they may have. And then secondly, we do have interventions that come from that CTSA, and one of those is what we call our Fishers of Men, which you talked a little bit about rural health. And rural health is very important for that area. And with our Fishers of Men, we actually had an opportunity to work with a faith-based community inside of a rural area, where we taught the men to actually be community health workers, if you will. And they did those really, really tough jobs of talking to their peers, getting health impact in health in terms of biometric change, and actually helping them to also sustain the model within that local community, where rural health and access to care is obviously a big issue. And so they were able to bring that in-house, if you will, both in their barbershops and their other local businesses in the area, and then through the faith-based community as well. So we're proud of both of those areas that we were able to impact, and it also is a model that enabled us to say, not only are we engaged with you, but we can also help you to understand, some of the dynamics in the academics and the measurements and SMART goals and milestones and things of that nature, and have that level of conversation so they can look at their own funding and prepare them to do that. We do grant writing, education, and other types of education for the local community for them to look at sustainable models for themselves.
That's really terrific. I feel like I want to sign up for some of your program initiatives there. So you've talked about some really terrific, successful community partnerships, and I love the different lens and weaving in our community perspectives. Can we talk a little bit the flip side of the same coin? So what are some of the challenges or barriers you've encountered in building some of these community partnerships?
That's an excellent question. And one of the biggest barriers that I would say is when you're looking at developing a relationship, with any relationship, you do have to have an honest conversation at the table. You have to understand that timing is important. So if you are the academic or you're the health system and you need the support of the local community or the community CBOs, then you have to make sure that you plan ahead. When you're looking at your intervention or your outreach initiatives, invite the community in at the beginning. So the information is being designed with the community in mind, rather than at the end when you realize that you're missing a population and you want to bring them in. So that timing becomes extremely important. And then we want to make sure that it's not transactional. You really do want to build partnerships. So it's not, let me give you dollars and you do a tactical something for me and then I go away. You want to build it as a partnership. So there's ongoing opportunities to collaborate on whatever initiatives that may be coming in the pipeline. And then, of course, I would be remiss if I didn't talk about funding. So there, from a CBO's perspective, there is something that size does matter. So when you're looking at a larger CBO, for example, then you have to realize that because it's large, oftentimes the money that really gets to the community is kind of parsed out by the time it get there. In terms of a medium or smaller CBOs, you have a better opportunity to reach the population that you're trying to serve. And then secondly, you want to make sure that in those opportunities as well, that most CBOs, except for the very large ones, are struggling with funds. So you can't have a reimbursement model. Those don't tend to work very well for us. We really prefer having models that there's some seed money up front, or there's some reimbursements for some smart milestones or something to that nature. But reimbursement model solely doesn't necessarily work, and that has been a huge model. And then finally, I have to talk about languaging. When we're talking about health systems and academic institutions, just realize that community-based organizations may not understand the language that you're speaking. So make sure that you keep it clear and understandable and simple, and offer a comfortable area where people can ask questions and not feel like they're being judged because of their question, which becomes very important to making sure that that partnership is a long-lasting relationship and not just a transactional one.
Yeah, thank you, Neicey. And Mark, when you talk about some of the challenges, and I want to pull on both your public and private sector experiences. So when you highlight some challenges that are coming to mind, can you also share with us if there are some distinctions, private versus public, or is it all the same?
Well, generally, when you're working in the private sector, it's for-profit, and your models are driven, and there's a hyper focus on being efficient and squeezing all the juice out of the lemon if you can, and for your for-profit, it's a little more services or community-based. So that's why I'm in tribal health now, because I feel like I can do more, and I'm allowed to be as creative as possible. We worry about third-party revenue because we still want new equipment, our tribal members. We want new services. We want specialists, specialty docs to come in, and that's a little bit pricey. But, we can bill for that, and then we offset the cost of bringing our specialists in. For-profit, although they do some charitable things, and, all private entities for-profit are not bad, but it just depends on kind of what their core is, You see some of our international corporations that making billions of dollars, and that's why you see a lot of some of our large retailers, I won't call any names out, that are constantly accused of coming in and change the dynamics in communities, and local stores that may have spent millions of dollars on baseball fields and donating to the community. These large chains will come in and maybe donate they'll spend $1 million in the advertising to advertise the $500 they gave, versus the stores that are no longer there anymore that were actually building ball fields and doing things for folks. So I think it's just being aware and being engaged, and again, it goes back to that communication. And I know in that particular community that message was sent pretty hard. But what I want to touch on, you're talking about advisory committees, and I wanted to talk about a really good experience real quick. Is in one of the health systems I went into, there was a lot of concern that there wasn't people listening to the community and the elders and the tribe, because they had folks that were coming in that were not from the area, and they felt like they were hiding or covering up bad medicine or bad mistakes. And I had a really hard time dealing with that. So I went and got a group of community elders, and I said, who can we put on an advisory committee that can come in, and we will train them on HIPAA, we'll sign them up, and we'll come in and not share patient details, we'll share the incident and show them how we do our quality improvement process and compliance and how we go through. And we actually had Oklahoma Foundation of Medical Quality on retainer, and we actually were able to independently, as our quality improvement organization, send cases to them. It was a double blind. They didn't know who the patient was or where the organization was coming from in their process, and the people doing the review also don't know. The identities are protected on both ends, but that gained so much trust in having that. And then that went from trust being built to enthusiasm, and well, let's talk about this, and we'd like to see this done, and we'd like to see, can't you guys do Cologuard instead of having us go out and do colonoscopies all the time? Mm-hmm. And it just really took off, and so again, everything goes back to that conversation and talking, and that's why coming to conferences and things like this is where people can talk and exchange ideas. I'm going to tell you guys, I feel like I'm pretty smart, but I've stolen most everything I've done, benchmarked from everybody, because there's a lot of smart folks out there doing some really good things. You just have to pay attention, kind of stay awake, and I always have to remember that the Osage people trust me to run their health system, but I'm the store manager at the end of the day, and I know that, and I have to keep my mind on who and what I'm doing and what I'm serving and making sure I'm delivering the things that they desire, and that's true no matter where you're at.
Mm-hmm. No, thank you for that. Alex?
I guess what I like to say is one of the best things about working with the LGBTQ plus community is that we're everywhere. And one of the biggest challenges about working with the LGBTQ plus community is that we're everywhere. So we are part of every racial and ethnic minority. We are a part of every religion. We are part of every geography. We are literally everywhere. And that means that it's sometimes hard to, one, get a good glimpse of what our community actually looks like. There is not great data on our community, specifically when you disaggregate that data by race, ethnicity, religion, and so forth. And also, it means that when you're talking about working in a healthcare setting or partnering to advance healthcare, equitable access to healthcare, you're not only dealing with the lived experience or the discrimination and stigma that someone has maybe experienced because of their LGBTQ plus identity, you're also dealing with, most likely, with brown and black LGBTQ plus people with decades and generations of historical trauma with healthcare. So you're dealing with compounding trauma that is going to occur both in their actual lived experience as well as in generational trauma that they've inherited. So there are so many things in which they're dually marginalized by and actually do not trust the healthcare system as a result. So trust actually takes that much longer to build and also to figure out how to actually meet folks where they are, because we also see a lot of populations that are less likely to identify publicly as LGBTQ+ because of experiences of discrimination. And I think the other big challenge at this moment that we have to be really cognizant of, and I like to make sure that any time that I get to speak that we get to highlight this, but we are in a very real health crisis in our community. 26 states have passed laws criminalizing basic access to health care for trans and non-binary children. So trans and non-binary children are being used as political pawns to stoke fear and ensure that folks can just grab onto power and really rob us of bodily autonomy. That's 26 states. So over 150,000 trans and non-binary children have lost access to evidence-based medically necessary care in this country. So on top of this generational trauma, on top of individual experiences of discrimination and stigma in healthcare settings, we are also seeing political establishments going after our young people and stoking more fear and even more mis and distrust in these institutions, which is a horrible crisis that will continue to affect our community for decades and decades to come. It's also sparked a massive migration crisis in our communities because the supportive families of those trans and non-binary children are moving to other states. And also, we're criminalizing the healthcare providers who provide that very care, that care. And they're actually leaving those states as well in droves. So a lot of these states already have crumbling healthcare infrastructure. We know there's a physician shortage all throughout the country. And now you're basically telling healthcare providers that the care they were taught to provide and that is based in scientific evidence is no longer legal. And that sort of like moral injury where your practice is guided by ideology and hate rather than like science and compassion is something that will drive people not only out of the state where they practice, but likely out of healthcare in general. So all of those things make it very hard to reach our communities where they are and also to engender that trust that's desperately needed to enable us to actually have meaningful and impactful community partnerships.
Yeah, no, I really appreciate you raising those points, especially, I mean, you are a policy person, and I think all of our leaders here on this stage have a lot of extensive policy experience. When that type of legislative movement is happening across the country so rapidly, I think so many of our communities are being attacked. We're seeing similar negative legislation, you know, the anti-DEI legislation, you know, that's another dimension that impacts our communities, and certainly on the women's healthcare, reproductive healthcare front. On the legislative note, I did want to highlight, you know, we've been talking about the unequal treatment report. How many folks have heard about the federal legislation called the Health Equity Accountability Act, or HEiA? Okay, I don't see too many hands going up, so thank you, good sir. So I want to raise that. It's over 1,500 pages, so I don't expect you to read it by tomorrow morning. But I do want to flag that because the Health Equity Accountability Act came about as a result of the first unequal treatment report. So that was the legislative solution. It's been reintroduced into Congress over 20 years, and it's what you can call model legislation. It's the Tri-Caucus that pushes it, which is the Congressional Black Caucus, the Hispanic Caucus, the Asian Pacific American Caucus, a few more other caucuses. And since we are talking about community partnerships, I also wanted to highlight, on one hand, it's model legislation, and that's why the bill just keeps growing and growing. And on the other hand, there is actually a community coalition that works with these congressional caucuses for input and a seat at the table. And to date, there are actually over 300 community organizations that are part of that coalition. I raised that there are 10 titles in it, anywhere from disaggregated data, workforce issues, access to healthcare, the need for language, the need for greater resources, supporting immigrant communities as well. I invite folks to take a skim at it, get yourself familiar with it. All the caucuses have a 2-pager about it. And it's model legislation because whatever your efforts are doing, you can take some of that framework and leverage that at your local, state, or even some of your national conversations. So just wanted to highlight that briefly. So in talking about the challenges that you've highlighted and tying this back to your earlier comments of how impactful these community partnerships can be, especially community advisory groups, and so many leaders who end up being volunteers at these really critical decision-making tables. Are we doing a good job of incentivizing more community leaders to come to the table? Is there a better methodology of acknowledging their worth, their contributions through compensation or some type of recognition?
That's an excellent question, and I'm so glad you raised it. One of the things that is important, you know, everybody intuitively believe if you give people money, then they will come. Actually, I believe that those are the people who you don't want, because I want you to come because you're passionate about the work. I want you to come because you're passionate about what we're doing, and I want your voice to be heard so you don't feel like you're being incentivized to be there financially. Recognition goes a long way. trust me with that one. One of the things that we were able to do through the Georgia CTSA is that we start allowing our community members to be the first author on any manuscripts that we were writing that they were engaged in. And that went a long way in terms of gaining goodwill, in terms of being able to say, you know, we need you to come back and do more. And they do, and they show up every time. The other thing in terms of recognition is that you want to go back to the community and share and disseminate the results of what you're doing. Communities are excited about being able to have the partnership, but they also want to know the outcomes and the impact that is being made. They also want to know that, you know, if it isn't good, why it isn't good, and how can I make it better? So don't diminish the value of having recognition. You know, obviously you want to give some resources if resources are available, but not make that be the focal point on why they're wanting to be engaged.
Great, thank you. Would anybody else like to respond?
I think that, you know, it's real easy to recognize folks. We have a monthly town hall meeting, and people in the community that help us with our programs or help us with our health fairs or any activity that's going on. We'll have them come to our health system, and we will recognize them at our monthly. It's an in-service kind of, we're closed for half a day, do all of our regulatory meetings, our P&T committees and meetings and all those things, and recognize folks. And like you said, it's sometimes you get a lot more mileage on that, I think, than if you give people monetary incentives. And a lot of times, if you have a good little trophy shop, find something that kind of represents your organization, spend a little money in recognizing folks. We're actually, for the first time in our area, we're going to have a banquet and annual awards program this year in January, and we're going to recognize all of our 2024 community folks, and also some of the volunteers, because we have a lot of folks that volunteer to make things happen.
Great, thank you. Alex, anything you want to add?
Yeah, I definitely agree that inducements can't be the only thing that brings someone to the table, but I do think that financial resources play an important part in equity, and that it's important to make sure that we are making, that people are able to afford their way to go places. We had an experience where our board, we did a retroactive look at how many people ended their board service early, and we found that new parents were the most likely to drop off of our board of directors because we didn't provide childcare and because we would meet at very random times. So now part of the way that we're trying to work some more equitable practices into our board service as well as our conference is to provide childcare, and that requires financial resources. So I do think there are ways in which we can balance the table just a little bit better with the use of financial resources. But what is, of course, so much more important than that is real, meaningful relationships and reciprocity, and making sure that if you have a decision-making authority in, say, one community group that you're in, that you have some community representative from that group on your decision-making, in your decision-making capacities. So we see a lot of strength in our partnerships with other health professional organizations where we have liaisons that go in and out of different leadership bodies, and we ensure that we have a voice at the table, but then they also have a voice at our table. So those two pieces, I think, have to be both recognized as important pieces of the puzzle there.
Oh, that's great. We have about 8 minutes, maybe 8.5 minutes left here. Would certainly love to invite, maybe, let's start with 2 questions. Anybody from the audience? And while we're teeing that up, I did want to share, listening to the stories that you shared, you reminded me how you really can effectuate change when you bring community leaders in. And Mark, I was honing in on, how you, you help to be a steward or ambassador to ensure tribal leaders come into the healthcare system. Just wanted to highlight, back in 2022, the state of Hawaii's Medicaid agency, which is called Aloha Care, did something very similar to that, bringing the community leaders in, bringing some of the Native Hawaiian leaders in, And so in the state of Hawaii, it's the only state Medicaid plan that I'm aware of. They are now covering services related to traditional healing, Native Hawaiian healing and practices. And I think just a week or two ago, CMS announced that in California, Arizona, New Mexico, and Oregon, working with Indian Health Service, they're now acknowledging natural healing practices as well. So really wanting to hold on to how bringing in community leaders can really effectuate change, not just service program delivery, but also legislation. Any comments or questions from the audience? Yes.
So I was wondering, because I was working with the nonprofit before. I know that if you don't have a 501c4 status, you can't really do lobbying work. And I was wondering, you know, do you have any tips or tactics that you can share, you know, if we're a nonprofit where we don't have the 501c4 status, how can we, you know, I guess, access and be influential on policy?
Yeah,
I can start that one. So there are creative ways that you can lobby without being a lobbyist or without actually lobbying to put your 501c3 if you're a nonprofit into jeopardy. And you do that by having conversations or going with coalitions, as we were mentioning earlier. Being a part of a coalition helps you to raise a larger voice. And oftentimes, the leads of those coalitions may have lobbying capability. What we have been able to do is, with the Association of Black Cardiologists, is to participate in HEiA days, where we are going to the legislative bodies and we're having the conversations and educating them about our priorities and what's important to us. Is that lobbying? You know, you can define it if you like, but we do not. It's conversational. And it is completely legal, so it's nothing that we're doing illegal. The other things with that is that we go from a grassroots level. So those community health workers that I was talking about, there's a subgroup of them that we provide them with basic education on how to have conversations with your legislative partners, how to, you know, talk about policy and what's important in your neighborhood. Is it air quality? Is it green space? What is that? And then having those conversations periodically, individually, or in groups. One of the things that we do in Georgia and one of our counties is that we've encouraged our legislative body, both at the state and local levels, they have a monthly breakfast. It's a community breakfast where they invite the community in to meet with the legislative bodies. And that is probably the most impactful breakfast and the biggest conversation that you can get. And it's usually centered around a topic, either it's a health topic or it may be an environmental topic, but it brings the community to the table to have those conversations. And oftentimes the CBOs show up because they have direct access at that point with the legislators. So,
Alex, I saw your mic go up.
Oh, just because I always love to make sure that folks are aware of this. Like, as a 501c3, you can use a certain percentage of your budget for lobbying activities. And I believe, if according to the IRS tax code, it is up to 10%. And how you calculate that is pretty fascinating. A lot of it is based on staff capacity that's used for that, and maybe not even necessarily volunteer capacity. So there is a lot of flexibility. And one thing that I have learned from a lot of 501c3 partners is that almost no one is even coming close to that percentage mark, especially among progressive organizations. And they are actually only using 1% to 2% because they're so risk averse. So I want to encourage every 501c3 in this room, any representatives, to use as much of your lobbying power as possible, because we need that as much power as possible. And also make sure that you are looking up the exact tax code and also looking at your state laws wherever your 501c3 is incorporated. But there are a lot of creative ways as well. As long as you are not mentioning a specific piece of legislation or a specific elected official or any electoral politics, you can talk about the issues themselves. So we have fact sheets about the dangers of depriving trans and non-binary children of gender-affirming care. We're not talking about a specific piece of legislation, but that resource can be used by people who then go and talk to elected officials about the issues. So there are ways to get around some of those things in creating general, non-specific resources that are vetted and are useful to folks who are in those advocacy spaces, but also like use your lobbying power. If you've got it, like use it as much as possible. We're trying to push that as much as we can.
Thank you for busting that myth. I mean, we just hosted our annual conference at the beginning of the month and had a workshop exactly on that. And every person I had asked in advance who was with a C3, simple question, can you lobby or not? And everybody said, no, you cannot. That is a myth. And so as Alex has highlighted, up to 10% of your budget, the way I look at it is, given the incredible voices we have, that is such an underutilized resource we have at our disposal. Mark, it looked like your mic was going up.
Oh, I was just going to say one of the things that, I've heard childcare a couple of times. Once again, that's something that we have young tribal members that have gone away to college and now they have kids and maybe they went through a divorce or had a life, something changed, and they want to come home. And we don't have enough child care capacity. And some of these folks are folks that, some of them are providers, some of them are RNs. And so child care is actually one of my biggest healthcare issues right now, not because of anything other than it's impacting my ability to maintain and sustain healthcare delivery, because we have people that are moving because they have, maybe they had somebody that's watching their children and they're not able to watch them anymore and they can't find backups. And so this has become an issue. So we're actually, my board right now has asked me to look at possibly having our own health system daycare for all of our workers. But that's an issue, I think, nationally that people are challenged with. And it was interesting, both you had mentioned it, and for various reasons, but we are actually having some big impacts with that. Thank you.
It's wonderful.
I did want to just circle back a little bit about the lobbying thing. One of the things you want to make certain that you have a clear process in place internally that is a documented process if you're going to, say we're going to allocate a portion of the budget towards that way, and you're following, because if you're audited, you know there's ways that they may say that you're doing something that you shouldn't be doing. So make sure that that documentation is there, and have those conversations with your auditors and your tax preparers to make certain that you have things that are in place. So.
I didn't think we'd start to wind down our conversation talking about auditors. Let's see. I think we're at time, and I'm sure I'm going to volunteer us to hang out for a few more minutes afterwards. The last thing on the lobbying piece, there's a great group out there, 4 C3s. It's called Alliance for Justice. And they have a wonderful toolkit. They've got webinars. If you're at a C3, I'm going to give everybody a homework assignment. Just take a quick look at their website. And then just the last thing, because the stories that you've shared, the folks that are here, my big takeaway is strategic partnerships really create synergy. And when you can create that synergy, synergy begets synergy. I think the last example I'll throw out there is my organization is a C3. Cancer equity is an area that we've been trying to lean into, but there's the American Cancer Society, and their C4 is the Cancer Action Network. So in terms of a strategic partnership, we've asked them, you have so many more resources than the whole of my community partners. Can we figure out a way where we can leverage each other? And so I'm really happy to share, just a few weeks ago, we did a joint congressional briefing on cancer equity for our communities. And I think that's something we can all do and replicate. So leaders, I've learned so much from you. Thank you so much. Alex, Mark, Neicey.
Thank you.